So I am a psychiatrist. I run the Washington Physicians Health Program. How many people in here who are not commissioners could, or staff, could give me a serviceable definition of what a physician's health program is or does? Well, good, there's stuff to learn today. We are the therapeutic alternative to discipline for physicians and other doctoral level healthcare professionals in the state of Washington who are suffering from illnesses that can impair your ability to practice. Psychiatric illnesses, substance use disorders, medical problems, virtually any health condition that could negatively impact patient care and put patients at risk. You can refer to us as codified in statute. We can take care of folks confidentially without the board knowing about it. And this promotes early intervention and treatment for physicians who are struggling with these problems. You might not be surprised to know that historically there's a culture of silence in medicine. We tend to not be comfortable addressing these issues in ourselves or our peers. We have mythological views about vulnerability and invulnerability and perfectitude that, and society, frankly, places us on a pedestal that makes early identification and treatment more challenging. Doctors are harder to treat than the general population for a variety of reasons, not the least of which is their specialized knowledge of healthcare systems and how things work that allow them to do things that sometimes circumvent and undermine their own treatment. So they need specialized treatment, and we provide chronic care management for a variety of conditions so that doctors actually get superior outcomes compared to most folks. And one of the things that has kind of been creeping around in there, both explicitly and implicitly during the course of this, is that patients don't really have access to what they need. Whether we're talking about chronic pain management, whether we're talking about substance use disorders, whether we're talking about mental health. But fortunately, through a program like ours, physicians have access to what I would consider the gold standard world-class treatment for these kinds of problems. And it's all basically chronic care management model stuff. And when people get the right treatment and they adhere to the treatments that we know are effective, they get outstanding outcomes. And in fact, treatment for mental health disorders and substance use disorders and these other problems are as good as any other chronic medical condition if one adheres to the recommended treatment. So I sort of get jazzed every day because I get to get out of bed and watch miracles happen with the treatment of healthcare professionals, watch them really come into our office having the worst day of their life probably, and leave our office some years later really having turned their lives around, both personally and professionally. So it's incredibly gratifying. So I guess that's why, for a couple reasons, that's why I'm here to talk about the connection between physician health and the opioid crisis. And what this talk really isn't very much about is how doctors' own health problems impact the health of their patient, although that'll be a little bit of it. We certainly know of cases in my work and in the work of the commission where individuals who are having problems with mental illness or substance use disorder, that can certainly have an impact on their patients. We see physicians who are struggling with addiction who divert medications as a symptom of their addiction and involve and collude with patients in that endeavor, sometimes both feeding their addiction, the patient's, and the physician's addiction. So we've talked a little bit this morning about how addiction sort of drives behavior that's pretty unsavory at times, and we do see that. And the idea is when that's happening, to get people a help. Now, I usually blow right through the disclosure, but I couldn't resist bringing up the fact that medicine for a long time has been co-opted by a variety of social factors, capitalism, other things that have involved us in things that may not have been in the best interest or health of our patients, but seemed like a good idea at the time. And right now we're dealing with, we still are in the midst of a horrendous tobacco epidemic, which I'll show you in just a second. But we're also on the leading edge. I mean, we're going down the path with cannabis that we're now at with opioids. And we don't know what the outcome of medical and recreational legalization of cannabis, what the health impacts are going to be of that. We're still going to have to wait and see. But we are, in many ways, by societal factors that are bigger than medicine, being pulled in to this process of medicalization and social approval of cannabis use that may not actually jibe with the science of cannabis and what we know about how cannabis impacts the brain. So I think we need to think about this, and we need to think about the fact that we've been down this road before, and what we think and our attitudes about these things, both in ourselves and in others, makes a big difference. I think we sit in these conferences from the perspective of we are the professionals, we're the providers, and we're talking about them. The people with chronic pain, the people with opioid addiction, the people with mental health problems. It's the them. It's not the them. It's the us. We are those patients in one way or another. If doctors are leaving medicine at unprecedented rates, and they're doing so by limiting how many Medicare patients they're willing to see, that worries me, because someday I'm going to be a Medicare recipient, and I'm going to need to be able to access physicians who provide services to Medicare patients, and if there are none around, that worries me a little bit. So we're all together. We're all bozos on the bus together. That's, I guess, what I would say. You know, so we're all in this kind of mess together. It's not us and the patients. It's us together as a society. So we've talked a lot about how to address the opioid epidemic, but what I've been impressed by through all the discussion about the opioid epidemic is we've not heard a lot about, one, how has the opioid epidemic actually impacted us as a profession? You know, there have been a lot of things not so flattering that have been said about doctors and about the medical profession and our involvement in this opioid epidemic. And I think in many ways we have been victims of the opioid epidemic as well as our patients. And there are lots of reasons why that is, and I'm going to talk to you about those reasons. But I think we need to validate that. We need to acknowledge that. We need to say that out loud in these settings where we're talking about all these things we should, ought, could have been doing all the way along to reduce the magnitude of this problem. We also have to think about how easy is it going to be to implement change in a healthcare system that is, for lack of a better way of putting it, broken in many ways. And it's broken in many ways that are making it very difficult for physicians to practice. Burnout rates are at epidemic proportions. Professional fulfillment is not great. People are leaving medicine. How are we going to tackle these big, complex problems with a healthcare system that's burned out, distressed, and frankly, you know, just trying to get through the day most days? I think we need to look at what's good for the healthcare system, what's good for our doctors is good for our patients. And if we're really serious about addressing some of these big, complex problems, we're going to have to look at taking care of the people who take care of the patients. It's an indirect way of solving the problem. Does that make sense? So this is CDC. This is kind of maybe a little bit of review of what other people have presented so far. This is from December of last year. It's basically the Morbidity and Mortality Weekly Report that gets cited everywhere in all the news headlines and journals. 18% overall reduction in opioid prescriptions, so we're making headway. Things are improving. Opioid deaths, however, are continuing to rise. We still have really these hot spots of high opioid prescribing counties that are prescribing at 6 times the rate of the lowest prescribing counties. 73% of the counties increase the duration of the prescription without necessarily increasing the dose, which overall grows the supply by 14%. Heroin deaths are up. Synthetic opioid deaths are up, and the overall burden of increased death seems to be related to this increasing use of synthetic opioids. Methadone deaths are down, and natural and semi-synthetic deaths are up, but less so than in prior interval increases. So we still have a pretty big problem here. But it's not the only problem that we have. So there's going to be a theme evolving here. So synthetic opioids killed about 9,500, 9,600 people last year. Heroin, about 13,000. All opioids, 33,000. But look at suicide. 43,000. Most people don't realize that for the past 15 years, we've been in the midst of an epidemic of suicide. Suicides increased every year, year over year since that time. Back then, it was about 10.5, 11 per 100,000 per year. It's now at about 13.5, 14 per 100,000 per year. It's a significance, 15,000 excess deaths in the United States due to suicide on an annual basis. So this is a big problem, but we're not hearing quite as much about it. But it's a complex problem, right? So the theme here is complex biopsychosocial problems that the healthcare system seems to be struggling with how to deal with and manage. Alcohol, our old friend, it hasn't gone away. Just because the opiates are killing people, alcohol is still killing lots of people, as is obesity, smoking. We're in the midst of a chronic disease epidemic, just overall chronic disease burden. You're seeing it in your day-to-day practice, but the epidemiology and statistics would validate your experience. And I would say, maybe most importantly, we seem to be in an epidemic of despair and hopelessness. I think a lot of these problems that we're seeing reflect how a society responds overall to the sense of its own opportunities, its own way of being able to be in the world in a way that's hopeful and optimistic and laden with opportunity versus feeling as though people have been lost and disenfranchised. We need to think about this because why is the suicide epidemic increasing? Why are we having increasing problems with addiction and opioid overdose deaths? This is the stuff of a society that seems to be unhappy. So how are we supposed to handle all this, right? Well, I think back in '92, Medicare said, you ought to be able to handle this in a typical primary care visit, defined as 1.3 RVUs, that should last about 15 minutes. Medical consultation. AMA helped with this, and that's how primary care reimbursement was established. By 2010, the mean visit for a primary care appointment was 20.8 visits. And when you look at this gets into the economics of our problem. 2 hours of primary care will buy you, depending on how many patients you see an hour, 3 to 4, 7.8 to 10.4 RVUs. 2 hours of hip replacement surgery, however, gets you twice as many RVUs, right? So we have some imbalances. Now we go back to Dr. Lozier's talk from this morning, talking about why there are so many surgeons in the country and why we're doing so many back surgeries, and you look at how RVUs are distributed, and it's not much of a surprise, right? RVUs, in case anybody doesn't realize this, are connected to dollars. So we still have this model of the 15 to 20 minute visit being adequate for most of our patient needs, but our patients are older and sicker. The demographic of the population, age has been increasing. A third of our patients have 3 or more chronic conditions. 40% are on 3+ medications. Complex biopsychosocial problem. Patients talk 85% longer when a mental health topic is the primary issue for their visit. Mental health topics take 37% longer than biomedical topics. And physicians, however, adhere to visit length. So, we're being driven by visit length. So the patients need more time to talk, which confines and constricts everything else that can happen. You have about 1 minute as a physician within these time constraints to establish rapport, generate a relationship, be convincing with a patient when they have one of these types of problems. It really requires that they spend the bulk of the time communicating with you during the course of the visit. It seems difficult to achieve. Is that anybody's lived experience? I'm just, show of hands. This is hard to do with really complex problems, right? So this is a great study by YAML, American Journal of Public Health, 2003. So this is like 13 years old now. 13 years ago, in order to implement all of the U.S. Preventive Service Task Force recommendations, Category A recommendations, would require 7.4 hours a day for primary care with a typical patient panel. Can't be done. We set up the game to lose. And we all went into medicine to win. We like to win. We took a lot of standardized tests to get into medical school and beyond, and we like to get all the answers right. We like to win. We like it when things turn out well for our patients. We work hard, patients get good outcomes, win. It's highly reinforcing, right? But yet the system over time has been increasingly set up and stacked against physicians being able to feel like they can win. I can't do all of the things that I'm supposed to be doing within the time allotted. This study by Sinsky, just hot off the presses. This is Christine Sinsky and the American Medical Association. Again, a follow-on of their time motion study came out a couple of years ago, the first one that showed for every hour of patient care, 2 hours of time in the EHR. So the follow-on study is they continue to follow these people around, time motion studies. Little people with clipboards walking around, actually documenting how much time people are spending seeing patients versus when they log into the EMR, and they like little stopwatches, and it's pretty rigorous design in terms of what people are doing and how they're spending their day. So in an 11.4-hour workday, which I think there's a problem probably there in terms of sustainability, but in an 11.4-hour workday, 6 hours of that day were spent interfacing with the electronic health record. So we've been through this, you've been through this. We don't need to spend time on this slide. I'm just pointing out that there's a kind of a long list on the CDC recommendations. And you just can kind of start jumping in here anywhere and say, arrange evidence-based therapy for SUDs. Well, that takes about 30 seconds, right? That's easy. Just arrange evidence-based therapy for SUDs. Non-prescription and non-opioid prescription is preferred. Of course it is. We don't disagree with that. But how do you have that conversation? Can you do that quickly? I don't think that you can. In fact, I don't think you can implement any of this stuff quickly. I'm not saying we shouldn't implement it. I'm agnostic in many ways or supportive of these recommendations. I don't think these recommendations are wrong. We just have to deal with a reality that we're overregulated, that we're overburdened, that we're overtold everything that we're supposed to be doing to take care of patients. That's okay, but we got to create an environment where we can win, right? That's going to be a theme. Real-world chronic pain management, not CDC recommended chronic pain management, but what's actually happening out there in the world. 21% of phone calls, messaging, meetings with the doctor between staff related to opioid and controlled substance prescribing. So that's a huge chunk of the effort in any practice just going to managing controlled substances. Many barriers and uncertainties in chronic non-cancer pain management. So when you ask family physicians about this, what they say are the barriers are no mental health services. Half of them will say there's no mental health services. A third will say there's no substance use disorder services available, and 41% will say they don't have access to pain specialists. Right? So they also acknowledge that pain is a complex biopsychosocial problem. And they say uncontrolled pain, 94% of the time is due to mental health issues that are untreated or inadequately treated. 3/4 of the time due to substance use disorders that aren't getting adequately addressed or managed. Poor pain coping in almost 90%, and poor life coping in 93%, right? So there's huge recognition that these are the reasons why individuals continue to have uncontrolled pain. And it's not like we haven't gotten the memo that alternative therapies can be helpful. And 70% of primary care doctors recommend and try to engage patients with alternative therapies. It's not like we're all out there just trying to push pills on patients and we don't know about these other things. We do know about these other things. It's just challenging to implement them effectively, right? And this is really telling, right? Is that 80% of PCPs in this study experience chronic pain treatment as a burden. Don't want to do it. It's no fun. Can't win. So I would say that if you've got 7 to 10 minutes to see a patient within the confines of a 15 to 20 minute visit because of the time that you're spending in the EHR and dealing with all the other nonsense, you've got to deal with, and we've already established through the course of this conference that the patients that we're dealing with, oftentimes, we don't know, maybe not. It can sometimes be uncertain. We don't know what we're dealing with, where the overlaps are. But this is a complicated situation. I challenge you to tell me of anything in medicine that's as complicated as this. I don't think there's much. Addiction has been defined as one of the most complex diseases in medicine, with biopsychosocial determinants that affects virtually every organ system. So that's just addiction. Now add chronic pain Now add mental illness. Is it any wonder that an opioid prescription is the outcome of this patient walking into your office when you have 7 to 10 minutes to manage the problem? If you have 7 to 10 minutes to manage the problem, the opioid is the only thing that you've got, right? We heard yesterday about all the reasons why people want opioid pain medications. They want it to relieve their anxiety. It helps their depression feel better for a while, right? They want to feel better. They want to sleep. So the easiest thing to do is kick the can. Kick it a little farther down the road and let's see what happens, right? We don't have a system that's really set up very well to start managing these problems. And the best thing we can do is probably never get people started in the first place, right? So we know that because we're all looking down into the abyss of trying to manage this with the patients that we've already got on opioids, and we're thinking, geez, maybe the best thing was to never start them on the opioid in the first place. So that's a good thing. I think that's a good thing. In psychiatry with benzodiazepines, I think we've been there. We've been living there for a long time. And the thing I teach the residents is, think very carefully before starting a patient on benzodiazepine. We know how to put patients on benzodiazepines. No benzodiazepine is FDA approved for long-term use, but try to get your patient off of a benzodiazepine once you've started it. It's very, very difficult. And for those of you who have seen patients who are chronic pain patients who are also taking benzodiazepines, it can be as challenging, if not more so, to get them off the benzodiazepine than it is to get them off the opiate. So if we don't know how to get people off of stuff, maybe we should be thinking very carefully about putting them on them in the first place. So to the extent that staring into this abyss will give you pause about even starting somebody on an opiate in the first place, I hope that we're thinking carefully about where this is going. So Anna Lemke, who's an addiction psychiatrist at Stanford and wrote a book called Drug Dealer MD. Anybody familiar with this book? So what she describes is the Toyotization of medicine. And I'm not talking about the quality and safety, stop the line stuff. That's good stuff. I'm talking about the assembly line mentality, tremendous pressure on doctors within the large integrated healthcare centers to practice medicine in a way, get patients out in a timely fashion, bill insurers at the highest possible level, make sure that patients are satisfied. Right, pretty tall order. So have you all heard the saw about the sign outside the print shop window? You can have it fast, cheap, or good. Pick two. So where are we in healthcare? I would just raise this as a question. Have we built a healthcare system that's designed to deliver good enough? Have we designed a healthcare system that's designed to do it fast and cheap at the expense of good? I think we have to ask that question. I think you will be challenged if you take this home with you to find violations of this rule. In other words, you can only have two, right? McDonald's may taste good, but it's not good for you. We have fast food, we have fast fashion. Do we have fast medicine now too? Is that who we are as a culture? Is that acceptable to us as a society? This is kind of our mentality as a culture. Quick fix, fast stuff, get it now, get it done. We can't solve complex problems like that. That's not the way complex, difficult problems get solved. One of the best papers that I've ever read on change management, if you search on Google, on Amazon right now, which you may want to do because you're probably falling asleep if you're not on your phone or computer. But if you look at Amazon and you search under the term change management, last I checked, you get about 36,000 titles. So what does that mean? That means nobody really knows how to do change, right? Millions of experts, but if it was all figured out, there'd be like 3 books, and there's not. There's like 36,000. So one of the best papers on this was Heifetz and Linsky's Adaptive versus Technical Change, Harvard Business Review, 2002. And they really differentiate. They talk about why do change initiatives fail? What's the problem? And the biggest, in their view, reason that change initiatives fail is that we're good at identifying and applying technical solutions to problems, but we are very limited in our ability to address the adaptive challenges. So let's take the opioid epidemic and let's think about a technical solution. So, PMP. PMP is a great example of a technical solution to this problem, right? So it's an easy to identify way to figure out who's getting medications from whom, when, and how much. Lend themselves to a quick and easy solution, well, relatively quick and easy, can be solved by authority or expert. So if you're in New York, you can legislate that people do this and they have to do it and people will check it, and you see problems go down. Now, Caleb said to us maybe they're not related, and they may not be, and maybe the PMP isn't the end-all be-all that we thought it was going to be. But it requires change in just a few places. People are generally receptive, and the solutions can be implemented relatively quickly, even by authority or edict. Adaptive challenges, on the other hand, difficult and easy to deny. So stigma would be easy to deny. We don't have stigma. We don't, I'm not biased about substance use disorders. I believe in the disease model, except, but, we have these implicit biases, and we might not be willing to acknowledge or address them. Am I really that concerned about these drug addicts who are dying? I mean, we got lots of problems. Maybe I'm a little bit worried about that. Maybe what I'm really concerned about is the extent to which the profession is contributing to people dying. As long as we can extract our own responsibility for these people dying by what we're prescribing, then we're off the hook. If people keep dying, will we keep caring? As long as it's not because we're overprescribing anymore? Those are the kinds of questions that we have to ask ourselves when we're thinking about adaptive challenges and adaptive solutions. Requires changes in our values, relationships and approaches to work. The people who do the work have to do the solution. It can't be solved by authority. It's the people in the trenches doing the work that will ultimately develop the adaptive solution. Usually requires changes in numerous locations across organization and bureaucratic boundaries. So we know the opioid epidemic is not going to be solved by one organization or by healthcare organizations without the help of regulators, without the help of insurers and payers, right? So the solution has to involve all of these different elements working together. It would require experimentation. I think another adaptive challenge is the physician health issue and the epidemic of burnout. That's another problem that we give a lot of lip service to, but we haven't done a tremendous amount of work in figuring out. I would challenge you to tell me one healthcare organization that's got this licked. Healthy doctors, though, give better care, and this has been established over and over in the literature. So going to Chris's question yesterday, Dr. Frank, about talking about what's the relationship. If you're a physician and you don't take good care of yourself, chances are that's negatively impacting the care that you're providing to your patients. If you smoke, you're less likely to counsel your patients on healthy smoking. If you don't get immunized, you're less likely to have patients who get immunized, and so on and so on and so on. So if you're a doctor with chronic pain who takes high doses of opioid analgesics to manage that chronic pain, you're probably more likely to do that with your patients. There's not one study that demonstrates this. I'm extrapolating from the existing data that connects how patterns of behavior. I say by extension we might believe that. We've certainly seen that in disciplinary cases. In therapeutic alternative discipline cases that come to me, we see that pattern. But there's no actual study that proves that. So I'm putting it out there, but I think it's something that we have to think about. How do my attitudes about cannabis and my behavior with relationship to cannabis or pain medication or alcohol, how does that impact the care that I provide my patients? Probably didn't think it does, but there's a good body of evidence that shows us that it does. And that when we're healthier, we give better care. Healthy work makes more than sense, it makes big dollars. So if you look at, Eddington did this really complicated and sophisticated economic analysis. It's been reproduced everywhere. You can hardly open a book on healthcare economics without looking at something that's been done by him. And really, what he showed was that, has anybody worked while ill? I mean, weren't we trained in residency that, like, if you're not, the only reason you should call in sick for work is if you're not controlling your bodily fluids, right? or your thermal regulators are out of whack. But basically, you should work unless you're dying. And that's part of the culture of medicine. And what it turns out is that when you take all economic costs into consideration, both direct and indirect, this is 2/3 of the cost of poor health to the healthcare system is due to the impact of working while ill. Lost productivity of working while ill, negative impacts to team, burnout, poor team functioning, the list goes on and on and on. This is direct medical costs, like, what it costs to actually take care of people who are sick. This is absenteeism. This is not STDs. STDs do not cause a tremendous amount of healthcare problems in employees. Maybe they do, but that wasn't what it meant here. It was short-term disability. And then what we always think of as a big deal is workers' compensation. And look at what a thin slice of the pie workers' compensation is compared to presenteeism in the model. Furthermore, it costs between $200 and $1 million over and over. This has been shown to replace a primary care physician, depending on how long it takes and how much lost billing, who you're able to hire in their place, and how long it takes them to get up to speed. But it's extraordinarily expensive to replace somebody who's been lost to the system due to poor health, due to burnout, due to egress, and choosing to do otherwise in terms of their professional life. So we've medicalized burnout because we're physicians, right? So we've decided, and the narrative that's developed around burnout is that burnout is an individual problem of the weak and vulnerable among us. This is an old story. We've done this with addiction. We've done this with mental health. But burnout is not a clinico-pathological phenomenon. There's no ICD-10 code for burnout. Some people argue there should be, because then we could treat people for it, and that'd be great. But there's a downside to characterizing burnout as an individual vulnerability problem, mainly that it labels and stigmatizes burnout, as does it label and stigmatize the treatments, the things that we could do. And when I say treatment, I'm already in that medical model again. It's not treatment, it's intervention. It's what we need to do on a systemic and individual level to address this problem. What is burnout? What I call prolonged exposure to situational stressors. And it's been operationalized by Christina Maslach as exhaustion, ineffectiveness, and depersonalization. Exhaustion speaks for itself. Ineffectiveness, not being able to accomplish the things that you set out to do every day, and the chronic feelings of frustration that result from that, and depersonalization or cynicism. We're just losing our connection to our work, why we went into medicine in the first place. We love taking care of patients. We love relieving suffering and making people better. And when we become disconnected from that, we lose the positive reinforcer that comes. All the stuff that we have to do to get to that positive reinforcer, we can slog through it until we no longer have that positive reinforcer anymore, right? It's just another case. It's not a patient. I think it's important to talk about what burnout isn't. Burnout is not depression. Some people have argued that burnout is just a variant of depression, and that's due to over-reliance on the exhaustion measure. Burnout is just exhaustion. As I just showed you, it's not. It's exhaustion, depersonalization, inefficacy when they all go together. We can all be exhausted. It doesn't mean we're burned out. I think we have to know what we're talking about for as often as we throw that word around. We really need to drill down into what we're really talking about when we say burnout. Or that burnout can be diagnosed by a cutoff score. Diagnosis, no. You don't diagnose burnout, right? We identify burnout as a relationship between an individual and their work environment. There's no clinical research that's established a diagnosis of burnout, and Christina Maslach never intended the Maslach Burnout Inventory to be a diagnostic tool. It's a research tool. It's designed to identify patterns in individuals that can then be related to other research to develop insights into the relationship between workers and the work environment and structure interventions to improve that. But she never intended it to be boiled down to a single measure, screening, cutoff. This is what people want to do with burnout, is they want to come up with a single measure that will identify who's burned out, who's not, so on. Can't do it. That's not with what the data that's out there. What isn't burnout? It's not all the D words: dissatisfaction, disappointment, demoralization, disillusionment. These things are all present in medicine too. But that's not burnout. Burnout is its own thing. And I think right now we tend to throw burnout around as the problem for a lot of things that, I'm just disillusioned. That doesn't mean you're burned out. You can be disillusioned without being burned out. So I think it's important to differentiate what the problems are, because we need to target our solutions to what the problems are. If my organization has an epidemic of disillusionment, there's probably a different intervention than an epidemic of burnout in my organization. Does that make sense? But if we're calling everything the same thing, then how are we going to know what to do to solve the problem? So I mostly throw this data in here to convince you that what you already know is true, is in fact true. These are the Merritt-Hawkins Physician Foundation survey results. They do a biennial survey every year. You can get it online. It's really interesting information. And it gives us a tone. It's based off of the AMA master file, and on the order of 20,000 physicians respond to this survey. It's considered pretty good data. 80% of physicians report being overextended or at capacity. No additional capacity to see other patients. Least satisfying elements, regulatory and paperwork burdens, and erosion of clinical autonomy top the list. It doesn't add up to 100 because people can pick 2 items. How about morale and feelings about the current state of the medical profession? Well, the news is good. Compared to 2012, we're on an upswing. Unfortunately, still less than half of physicians responded in this survey as being somewhat positive about the current state of the profession. And things break down around age. Older doctors tend to be less positive. Male and female, about equally positive. Owners, less positive about the current state of the healthcare system versus employed physicians. And primary care, more satisfied about the current situation than specialists. Oops. How about the future of the medical profession? Again, pretty disappointing, right? Down from 2014. In 2016, only roughly a little bit over a third of folks were very or somewhat positive about the future versus, and the vast majority of people, respondents being very negative. Again, breaking down by age, older folks tending to be more pessimistic about the future, but the numbers aren't great across the board in terms of people feeling optimistic about the future of healthcare. 48% of physicians in this survey said they plan to reduce their involvement in direct clinical care activities. If true, and people don't always do what they say they're going to do on surveys, but if true, this would represent 300,000 FTEs of physicians leaving the workforce in the next several years. Can you imagine what a problem that would create for the healthcare system? 300,000 physicians leaving. The point is, physicians are willing to vote with their feet. We think a lot about, when we talk about burnout and health and impairment, we think about the doctors who are creating a problem in the system. But what I worry about are all the doctors that are quietly figuring out other ways to get out of Dodge. Right? The ones that are quiet, it's like the air leak in your tire of your car, you know? You don't realize it until the tire's flat. But this is going to be a real problem for our system if nobody wants to work in it anymore. How are we going to solve the suicide epidemic, the opioid epidemic, when the people who are in the best position to solve these problems no longer want to work in the system? Or if they do, they're too overburdened to deal with problems of this complexity. So what's the true burden of burnout in healthcare professionals? The answer is nobody knows. There are lots of ways to measure it. The people who like to measure it tend to overcall it, I think, based on one measure. So a lot of the Shanafelt data that people like to cite from Mayo is one symptom of burnout. Well, that's not burnout, according to Dr. Masloch. So are we really in an epidemic? I don't know. This is the Leiter-Schaffelli database. Masloch and Leiter have made a career working together on the issue of burnout. And what they call the critical burnout group is this folks that answer 5 or higher on the Masloch burnout inventory for emotional exhaustion, for example. And they would call this, folks potentially in the critical burnout group. That's only 7 to 9% of the entire population. So whether we're dealing with symptoms of burnout or precursors to burnout versus full-blown burnout, I think there's reasons to have some questions about that. And again, are we calling dissatisfaction, disillusionment, and lack of professional fulfillment burnout? And is that the accurate thing to be calling it? And then, what about the scores on cynicism and efficacy? So Leiter and Maslow, 6 areas of work life. What are the things that matter in terms of the work environment? Well, workload, obviously, control and autonomy. We just saw the data that shows that the erosion of clinical autonomy is one of the things that is most troubling to physicians in day-to-day practice. Reward, and this isn't about money, this is about appreciation, right? How well is the individual appreciated? What's the community like in which one practices? Is it a community of incivility? Incivility is rampant in healthcare. And so how do we create cultures of civility where people can tackle difficult and challenging and stressful problems, but do so working together collaboratively in teams? What's the perception of fairness? I'll talk about a case a little bit later about fairness, but this hospital, well-intentioned, had this, these outstanding employee awards that they would give out. And that sounds really nice, right? And good recognition initiative for the organization. Turns out the employee side was horrible and horribly unfair, because the only way you could get this award is if your supervisor cared enough to take the effort to nominate you. So some people knew that they would never be eligible for this award because their supervisor would never nominate them, because their supervisor never nominated anybody, right? So in a system like that, you have this situation where people get rewarded and recognized in a way that's unfair, and they feel that unfairness. So well-intentioned efforts can actually generate a sense of unfairness. And values, and this is values mission mismatch, right? If I have to call in a prior authorization and I'm really trying to get my patient the care that I think that they need, and I might have to say some things or bend the truth or spin it a little bit, does that make me feel good to tell a lie to get the patient what I think that they need? Might not. Might. There's no judgment in here. No judgment about this whatsoever. Some people, if you're Machiavellian, you just say, hey, this is the way the rules of the game, and I'm going to play it, and I'm going to get my patient what they need, and I don't have any problem with that. And that's okay. There's love for you in the world, right? And then there are other people who every time they have to do that, it darkens their soul just a little bit more, right? And so where you have these things where people are having to do things on a daily basis that run against their values, and you're putting them in a position to do things that run against their values and why they came into medicine. And then you have these different profiles. So given those 3 areas that I showed you, burnout is really only 3 high negative scores, but then you have these different profiles. You have the disengaged physician who's high only in cynicism. You have the overextended physician who's high only in emotional exhaustion. You have the ineffective physician whose high score is only in efficacy, and then you have engagement, no negative scores. And when you look at large samples of this data, what you realize is that this is not a canvas that we can paint with a single brush. That we have lots of different types, and that we have 30% of the folks just about are engaged, which is good. They're doing some things that are working for them. We have about 20% that fall into the ineffective range, 17% overextended, 19% disengaged, and 15% that are burned out, meaning high scores in all 3 areas. So maybe not as high, but that doesn't mean we don't have problems. That doesn't mean, but the problems, if it's overextended, that's a different problem. And that points us to some different solutions. Then we can focus on things like workload and control. And those individuals, when you look at it, will rate their experience within an organization along these dimensions differently than somebody that's completely burned out, for example, or somebody that feels inefficacious. And that again points us to different models for improvement. This is the Stanford Physician Wellness Model. Stanford WellMD, Google it, it's great. There's a ton of resources in here for looking at the broader spectrum of what we call professional fulfillment. So burnout, I think, has become somewhat not a helpful term, but I think in terms of the whole picture of professional fulfillment would likely drive improvements in how we manage chronic pain, improvements in the opioid epidemic, improvements in mental health and suicide treatment. And professional fulfillment, according to the Stanford model, really has 3 major dimensions. Culture of wellness, efficiency of practice, and personal resilience. So too much of the dialogue has been about, well, is it on the doctor to go do some yoga and some mindfulness-based stress reduction? You know, there's pretty big backlash when you as an organization try to set up a physician wellness program, and that wellness program is go do some mindfulness-based stress reduction. We'll pay for it. And the docs are like, decrapify the work environment. And maybe I'll have time to go do your damn MBSR. Right? That's what we want. But it really is both, right? We are not good at self-care as a profession. I have a whole other talk that I could give you that would hopefully convince you beyond a shadow of a doubt that as a profession, we both think that we are immune and invulnerable, and we take relatively terrible care of ourselves. Even though we still have as good health outcomes as anybody else. So I hate to say that, because we live a little bit longer than most people, and we have pretty good health outcomes, largely driven by the fact that we don't smoke. But that's it. All right? Everything else kind of stinks. So, culture of wellness, efficiency of practice, we know, and personal resilience. It's got to be all three. If you really want to make a difference, and Shanafelt and Noseworthy, they say the same thing. But let me show you a little bit more of the Stanford data. So this is 1,200 physicians in the Stanford system. So if we just talk about burnout, in their data, the key driver of burnout was personal resilience. So if we're being clear about our concepts and we want to do something to really impact just burnout, not professional fulfillment, but just burnout, then personal resilience can go a long way, but it's not what you think. Okay? Self-compassion, being low in self-compassion increased your risk of burnout threefold. Sleep-related impairment was a close second. Sleep-related impairment. What's the solution for sleep-related impairment? Yeah, don't go to MBSR. Get a good night's sleep. Right? That's what you need to do. Meaningfulness of clinical work was inversely related. So what they showed is that self-reported burnout is increasing in their population, which coheres with the national trend. So that wasn't surprising. But what was really interesting was this issue of self-compassion. So if you were in the lowest quartile of self-compassion, you had the highest risk of burnout. 60% of that group was burned out. I'm going to tell you what self-compassion means in just a second. This is the sleep stuff. So look at this, right? So 235 of the docs in the high sleep impairment category with a burnout odds ratio of 35.47. When was the last time you saw a study with an odds ratio of 35.5 risk for burnout? Pretty big increased risk based on sleep impairment. Sleep is like the thing. In 10 years, we're all going to know that sleep creates problems with cognitive function, that it's a predictor of dementia. I mean, the data's already coming out, but like sleep is like food and exercise. Like, we need to sleep. Hate to break it to you. If we cheat ourselves on sleep, you do have to pay the piper. So self-compassion is really interesting. So this is like how you treat yourself, right? And it's interesting how we treat ourselves. It's interesting to look at what our internal self-dialogue is. When physicians are being sued for malpractice, that's a really good crucible under which to understand how physicians talk to themselves. Because in mentorship models where physicians get mentored by a peer who's also been through malpractice, they have the experience of learning about how we talk to ourselves. And physicians learn how to talk to their colleagues in ways that are very supportive, that they wouldn't talk to themselves in that same way. Had the same thing happen to them, they would beat themselves up, that they would tell themselves that there should have been things that they'd done differently. We almost would never talk to another individual the way that we talk to ourselves, right? So you have to look at that. When I made a mistake, I felt more self-condemnation than self-encouragement to learn from the experience. Less compassionate with myself than I was with others. Put off taking care of my own health to help somebody else. Taking care of my needs seemed incompatible with taking care of my patient's needs. So this is the measure. This is like you score high on this, you are more likely to be burned out. So now looking at key drivers of professional fulfillment, those were really driven by perceived appreciation. So we go back to the Maslow-Leiter areas of work life and think about rewards. Perceived appreciation is a huge reward. Values alignment and peer supportiveness. Together, that accounted for 40% of the variance in professional fulfillment. And that was all mediated by leadership support. So leadership support turns out to be a critical factor in all of this. Professional fulfillment, again, 2013 to 2016, down. So let's talk about this culture of wellness leadership support issue. So in the highest quartile of perceived support from leadership, you have the highest professional fulfillment. So there's this dose-response relationship from lowest perceived support from leadership to highest in terms of professional fulfillment. Very dissatisfied to very satisfied. This is the Shanafelt data. This was a composite leadership score. It's a 60-point scale. And what Shanafelt showed is that for every 1 point increase in leadership score of your direct supervisor, who's a physician, you have a 9% increase in satisfaction with the organization. 1 point on a 60-point scale translated into a 9% improvement in satisfaction. So leadership plays a key role in professional fulfillment and in the organization's ability to respond to and deal with challenges by mobilizing the resources that are present in all of you. And then efficiency of practice. And they asked the docs at Stanford, what interventions do you think would be most helpful to improve efficacy of practice and efficiency of practice? And they said, physician empowerment. This is what we mean when we talk about engagement. Engagement is a term that's thrown around a lot. It actually means involving physicians meaningfully in the decision-making process about what goes on in the organization, which is, we've been really marginalized over the last decade and a half in that regard. Physician involvement in decisions regarding support staff and how support staff are used. As we've gone to the EHR, we've created an inverted pyramid where things that other people used to do now rest on the backs of the physicians to get that into the database. We need to correct that problem. Documentation assistance, and so on. So the way forward. So I'm mostly just going to throw a bunch of stuff at you. It's like spaghetti, throw it on the wall, see what sticks. This is for what's in your packet so that you can look at it later and go kind of look around and get some ideas. But the point here is that the Mayo Roadmap and the Stanford WellMD models all involve interventions at these different levels, at the level of the individual, at the level of the work unit, organizational, and at the national level. And it breaks it down, again, by these areas that are important, like workload and job demands, efficiency and resources. In other words, we're developing these models. These models are out there, and they can be used. This is how the quality movement started in America, right? We did the same thing. 20 years ago, nobody had a chief quality officer. Now, most healthcare organizations have somebody in the organizations that's primarily responsible for quality and safety within that organization. Personal resilience. So this is the basics, right? Healthy sleep, get aerobic exercise, do the Mediterranean diet, mindfulness and compassion cultivation, and make some healthy relationships. I could talk to you a lot about mindfulness, and I know I've kind of been poo-pooing it, but I do want to show you a quick video that does a better job than I can do.
You may have heard this word mindfulness. It's become something of a buzz phrase of late. So I'm going to give you one simple, serviceable definition, which is this. Mindfulness is the ability to know what's happening in your head at any given moment without getting carried away by it. Imagine how useful this could be. Just as an example, you're driving down the road and somebody cuts you off in traffic. How do you normally react? I think most of us, we normally react by having a thought, which is, I'm pissed. And then what happens next? You immediately, habitually, reflexively inhabit that thought. You actually become pissed. There's no buffer between the stimulus and your reaction. With just a little bit of mindfulness, in that same situation, you might notice my chest is buzzing, my ears are turning red, I'm having a starburst of self-righteous thoughts, I'm getting angry. But you don't necessarily have to act on it and chase that person down the road, screaming at them with your kids in the back of the car thinking you've gone nuts. Now, you might be thinking, don't I need to get angry sometimes? Aren't I justified? I would say yes, but probably not as much as you think. The proposition here is not that you should be rendered by mindfulness into some lifeless, non-judgmental blob. The proposition is that you should learn how to respond wisely to things that happen to you rather than just reacting blindly. And that, my friends, is a superpower. How do you get it? The way to get it is through meditation. I believe that meditation and mindfulness are the next big public health revolution. In the 1940s, if you told somebody you were going running, they would have said, "Who's chasing you?" But then what happened next? The scientists swooped in, they showed that physical exercise is really good for you, and now all of us do it, and if we don't, we feel guilty about it. And that's where I think we're headed with mindfulness and meditation. It's going to join the pantheon of no-brainers like brushing your teeth, eating well, and taking the meds your doctor prescribed for you. Let me just close by saying, mindfulness is not going to solve all of your problems. It's not going to render your life a nonstop parade of unicorns and rainbows. Nonetheless, this is a superpower, and one that is accessible by you immediately.
So mindfulness is just the currently packaged, in vogue term for something that's been around for about 3,000 years, and if not longer. And frankly, things don't tend to hang around that long if they don't work. So I think that there's something inside of this that we need to pay attention to. And I think as we're thinking about our overall wellness and how we take care of ourselves, mindfulness work is brain work. It's healthy brain work. And if you want to take care of your brain, this is what we do. It's clear based on the number of publications that are now coming out in mindfulness related to all manner of medical conditions that there's value in mindfulness in terms of pain management and a variety of health conditions. There are apps that you can use. I don't work for or get any money from these apps. I'm just showing you that there are great apps that can introduce you to meditative practice. It's accessible to everyone. People make a big deal out of it and overcomplicate it. It's really like if you can sit for 5 minutes and focus on your breathing, you can meditate. And the more hard it is for you, the more practice you're getting. Mindfulness, all of these outcomes in a group of therapists who were trained in meditation versus those who were not. So patients, global severity index, somatization, insecurity, obsessiveness, anxiety, anger, hostility, phobic anxiety, all different outcomes for the therapists who had been trained in meditation versus those who had not. That was the only difference. Treatments they got were exactly the same. So, and you know, the great equalizer is that we're all getting older, hopefully. It's better than the alternative. And the negative correlations between gray matter and age in meditators versus non-meditators. So in the group, controls who didn't meditate had more gray volume loss over time than the meditators. So we think that meditation is actually doing something neurobiologically that's helpful. Now, what about self-compassion to reduce inflammation? So this was a great study where they looked at IL-6 levels in folks. They exposed them to torture, which is called the Trier stress test. Anybody familiar with the Trier stress test? The Trier stress test it takes about 15 minutes to administer, and basically what you do, it takes more than that. It takes about an hour overall. But you get 5 minutes to prepare a 15-minute presentation for a job that you're applying for in front of several people dressed in white coats who are trained to look at you judgmentally the entire time that you present that. Upon completion of that presentation, you are then asked to subtract 13 from 1,020 for the next 5 minutes. And if you make any errors, you have to start over again in front of this judgmental group of people in white coats. And at the end of that, they tell you, thank you for participating. This was a Trier social stress test. The goal was not to make you feel like a fool, but to put you under stress. Then they go and they measure this inflammatory marker. And it turns out that the people who were in the high self-compassion group manifested a significantly lower immune response in response to the Trier stress test. So self-compassion seems to have an effect on how we respond to social stress. And I'm getting the signal that I need to hurry up. You can learn compassion through programs like Compassion Cultivation Training, the Stanford School of Medicine. You can go to the Greater Good in Action website to learn things, interventions that you can do with yourself to improve your life, satisfaction, and health. These are all things that have evidence base to them. I do 3 good things with my kids every night at dinner table or at bedtime. It's a way to build gratitude, which is connected to happiness and health. I challenge you to give yourselves 3 hours per week of non-negotiable, unscheduled time where you just do what comes to mind. I challenge you to do this. I think that you can find 3 hours in your week to have unscheduled, non-negotiable time. And I think if you do, you will, well, the results will speak for themselves. Email me about what happens. People want to know, what's the magic of change? Well, Gabrielle Oettingen from NYU spent her entire career as a psychologist studying motivation and change and what moves people. She's developed an app and a program called Whoop, whoopmylife.org, and it's based on the principles of mental contrasting with implementation intentions. In other words, we've labored under the last 30 years of positive thinking psychology that tells us if we just visualize and imagine what we want to be true, it will magically happen. Turns out that doesn't work. When we positively think about things, we actually decrease our chances of getting the desired outcome. We set unrealistic expectations for ourselves. What we need to do as part of this program is we develop a wish. I wish I exercised more. Outcome. If I exercise more, I'd probably be healthier and I might make it to my kids' graduation and actually live to see grandkids. Obstacles. What kinds of things are going to get in my way? Oh, I'm going to have to see a late patient. I'm not going to be able to get to the gym. I'm going to be too tired, blah, blah, blah. And then the plan in the form of if-then statements. So if I feel too tired to go to the gym, this is what I'm going to do. I'm going to go to the gym anyway, and I'm going to work out half as hard, and I'm going to see how it goes. You develop this. This is a strategy that's been proven again and again to work for developing change. Developing the culture of wellness, moving now beyond personal resilience factors, peer mentorship, professional coaching, which is really underutilized in medicine. In the rest of the world, where business is business, it's actually like, you're in the cool kid club when you get a professional coach. Like it's expected that you should have a mentor. I think as healthcare professionals, we should have the expectation of ourselves that we're always working with a mentor. It doesn't have to be somebody that we're paying $500 an hour to professionally coach us. It just could be somebody that we respect, that we get together with from time to time and talk about our professional development and how things are going. There are consultation groups that people can form. Getting involved in your professional society. I hear time and time again that involvement in professional societies, involvement in the medical board or the osteopathic board or other types of involvements, they take time for people who are, yes, already busy and stressed, but the reward out of it in terms of connection is so important. And so people have learned who do these things that they can't really afford not to do them, even though it does cost them additional time. It makes all the rest of the stuff more meaningful. I told you about the fairness intervention. This was a large healthcare organization where Christina Maslock and her team went in and did a fairness intervention because they were rating their fairness very low. And what it turns out is that when they just focused on one area within the organization to improve that issue of fairness, just about everything else improved as well. Just focusing on one intervention within the organization. So it's possible. This was just a year of interventions designed to improve fairness in the organization, targeting that improved workload, perception, control, rewards, and community. Values, not so much, but they improved. They just didn't get above normal. These are things to develop physician leadership. We need physician leadership development at all areas of the organization. We need to coach them. We need to teach physicians how to be supervisors and how to be leaders. People think that they can bootstrap this. There's actually a whole science. People actually go to school and get master's degrees and beyond in organizational leadership and business administration. There's actually science to this. We can't just figure it out because we're smart doctors. Right? So there are things that we can do to become more effective and better leaders in our organization and take back that which has been taken from us. Efficiency of practice requires collaboration. We can do team-based care, clinical workflows, and technology innovations, but we can't do it alone. We have to work together with other people. I just put this paper in here because it's hot off the presses again. This is Annals of Internal Medicine, and this is putting patients first by reducing administrative tasks in healthcare. It's a great paper that looks at how we make decisions about what doctors should and shouldn't be doing from an administrative task standpoint. EHR, we just need to recognize that a lot of stakeholders, in terms of how the EHR is constructed, what it's used for, whether it's user-friendly to us, and when we understand who the players are, we can think about developing collaborative solutions. What is the EHR designed to do? And then finally, again, hot off the presses, September 25th, 2017, this is the future. This is what the AMA is working on, the section on physician wellness and satisfaction. This is developing calculators and tools to make the business case for why physician professional fulfillment matters in terms of dollars and cents for the organization. And this calculator that just came out, and there will be more coming, this was Tate Shanafelt and Christine Sinski. Tate's leaving Mayo, going to Stanford to their WellMD program. Christine Sinski is the vice president of the AMA's group on on physician well-being and professional satisfaction. Cost of turnover alone. So just considering cost of turnover in an organization that employs 450 physicians, a $1 million in well-being investment with a targeted relative risk reduction burnout of 20%. In other words, 50% of the population of physicians burned out at time one. At end of intervention, the hope is to have only 40% of the docs burned out. Would be a return of investment of 12.5% or 1.25 million, just in terms of the cost of turnover alone. And this is based on lots of data. You can read the paper and see how they sort of put this together and created this calculator. But this is really about physicians taking back the business of healthcare and really demonstrating that good care translates into dollars and cents and good business. Finally, I would just leave you with the notion that we can't CME these problems away. That sick eats smart for breakfast. We got lots of smart people in the room, but we need to be healthy. We need to be at the top of our game, and we need to put first things first. And if we want to be really good at tackling some of the problems that we've been hearing about over the course of the last 2 days, we need to start here. We need to make sure that we're taking care of ourselves so that we can take care of other people. The opioid crisis and other epidemics that are killing us and our patients are system failures, not physician failures. I think there's been a lot out there that's made us feel like we're the failures in this. We are not. We are part of an overall system that has failed our patients in many ways. Addressing complex problems involves the technical and the adaptive challenge. Workplace and wellness are key targets for adaptive change. I've pretty much said everything else. I'll be around if you have questions. Thank you for your time.